welcome very much everyone to this talk for the BPF. Entitled The Vulnerability of and the Risks to Workers in the Mental Health Services during the COVID-19 lockdown.
Thank you very much, Tim. Can everybody hear me? Is this okay? Yeah? Yeah? Okay. I'm not going to talk for more than half an hour because, as you'll all realise, this is a discussion document. There's nothing final to be said about the way we're working these days and how we're finding our way through this situation. So what I'm aiming to do is to raise a number of questions and attempt to explore these by focusing on experience of workers from the beginning of lockdown, mid-March, as Tim noted, to the easing of this at the end of June. And of course, things have moved on again. But to start, this is the introduction. Working lives changed dramatically in mid-March, as overnight we were all required to find new ways of managing. Everyone, apart from those deemed to be essential workers, was expected to stay at home in order to protect themselves from infection and protect the NHS from collapsing under the deluge of near-death patients. Hospital-based health workers came face to face with the terror and risk. People unable to work had to find their way around the support measures put into place by the Chancellor, and a vast number of people were shut out of their places of work, thrown into the unknown, searching out new ways of continuing their activities. All felt anxious and vulnerable. Mario Perini, writing in 2012 with the title Panic and Pandemics, begins with this statement. From time immemorial, epidemics threaten man's survival, mental peace, and the social order that man has come to create. He concludes, in order to deal with challenges involving anxiety, fear, and panic for thousands or even millions of people, we also need to better understand these human emotions, the way they develop, what may enhance or mitigate them, what their psychological and social dynamics are, how they impact on the individual and group behaviour, as well as organisational functioning. These are matters that we all muse on while attempting to manage our home and work lives. Now, in focusing on the vulnerability of workers during this pandemic, I won't be referring to those on the medical front line, whom we've heard a lot about. Instead, I invite you to consider the vulnerability of the staff we didn't hear about, those working to keep their community-based mental health services running for their needy and vulnerable clients, many of whom may also pose a risk to themselves or others. In doing so, I will also make reference to the experience of therapists working in private practice, and I will use the term client generically to include patients, clients, and users of a range of mental health services. So, first heading, doing what highly anxious people can't do, Beyond's theory of container contained. In a chapter entitled Thinking About Risk in '98, I proposed that the real task of professionals in mental health work is to do what highly anxious and disturbed people, communities, or systems cannot do. That is to think whilst keeping in mind the disturbing and conflicting aspects of the situation, at the same time as being sufficiently detached from the client to assess the situation on a regular basis. Work of this kind gives rise to considerable anxiety, and we know that increased levels of anxiety obstruct our thinking. While a degree of anxiety may be helpful as a motivator, too much anxiety causes us to split off part of our awareness and inhibits our ability to think. So we may become paralyzed or tempted to rush into action or explain away what should be first tolerated and understood, resorting to these and other unconscious mechanisms as a means of avoiding the discomfort. Beyond urges us to acquire a state of patience, tolerating suffering and frustration with the faith that meaning will ultimately be found. This he links with the term negative capability, described as the capacity to bear uncertainty, mystery, and doubt without any irritable reaching after fact and reason. Some authors have emphasized the use of such capability as a specific quality of leadership, particularly in turbulent conditions or environments. And if we make a brief political aside here, we haven't seen a lot of that, I propose. So we need the state of patience when mind, thought, and linking are under attack from the pressure of primitive anxieties. Linking this state of patience with reverie, Beyond describes a process of container-contained, whereby the mother's availability, patience, and capacity for reverie enable her to make sense of the infant's fragmented and disturbed experiences and give them back to the infant in an understandable and manageable form. This process is paralleled in well-functioning teams. Team members need safe, reliable meeting places in order to detoxify and explore their experience. In community mental health work, the team home base, where daily contact is possible, acts as a physical container for the meetings, which I propose are the emotional container, and the sharing of work experiences, the contained. Teamwork, which importantly includes informal activities as well as team meetings, supervision, and reflective practice, helps us process our anxiety and promotes deeper understanding of whatever it is that we're faced with, leading to more insightful and creative interventions. Knowing one has the team base to return to and team meetings to aid the work enables staff to locate and hold on to a state of patience. For clients too, the continuity of the setting and the reliability and frequency of face-to-face contact is a significant element in the work. Yet overnight in mid-March, all except for 1 or 2 staff were shut out of their team homes and separated from their colleagues and clients. All daycare and group work ended and hospitals discharged their patients back into the community when all but the most essential home visits were suspended. Both workers and clients were left wondering how they might deliver and receive a comparable level of care in this new and unprecedented situation. And I know we hear unprecedented on a daily basis these days, but I do justify the use of it here because it really is unprecedented for people working in this field. Everyone was feeling anxious, disturbed, and vulnerable. With the familiar physical and emotional containers no longer accessible, we had to consider how this would impact on the risks to both clients and staff if work could only be conducted remotely. Would we be able to recreate some of the therapeutic community via remote means? So next heading, remote working, the impact on the client-worker relationship. What is the impact on our clients and on our therapeutic relationship when instead of coming to us in the team home, we regularly go into their homes via their phones or computers? And of course, this is the same for you in your private practices, isn't it? Initially, workers only had access to mobile phones with withheld numbers, which meant it was the worker, not the client, who announced their arrival for a meeting. The client could then decide whether or not to take up the offer, and once answered, could, if they chose, abruptly end a meeting by simply hanging up. The client was also the one who determined where the meeting would take place and whether or not to invite the worker into their home. What was the worker to do when the client didn't answer? Simply treat it as a DNA, did not attend? Or was the concern for the client and the worker's anxiety such that further action was deemed to be necessary? Home visits were not allowed, so was the worker pulled into making more and more phone calls, the equivalent of multiple appointments? Was the worker left holding the desire for both of them? At such times, it can be helpful to ask, what would I normally do? And then look for an approximation of this in order that the container for the work isn't stretched out of shape any more than the circumstances require. Similarly, with the aim of keeping things as normal as possible, once workers were given work mobiles and laptops, it became possible for clients to arrive for meetings and announce this via text message or website waiting room. Some clients seem more comfortable with remote working, speaking more freely when not seen, while for others, visual clues form an important part of their experience and aid mutual understanding. Workers too will have their personal preferences. Several workers and some clients have reflected on additional feelings of loss because the work isn't embodied. One worker has said he feels better connected when he looks away from the screen because the other's voice is in the room and he's not faced with an absence. Alessandra Lemmer's paper, written in 2017 about the use of Skype for therapy, has been widely circulated during this lockdown. She identifies some of the difficulties of mediated therapy to be, perhaps rather paradoxically, the loss of boundaries and consequently a greater risk of acting out in a countertransference. Indeed, others have commented on the tendency to chat more and an urge to divulge personal information. Might the element of chat be a form of compensation for the loss of the setting and the human contact? The client's choice over where they will meet their worker has led to some interesting revelations and speculative interpretations. Workers have found themselves in a client's bedroom, in the bathroom, on the roof, in a car, or taken for a walk. Being risk aware. Perini invites us to explore the link between infectious and mental diseases, stating that the connection is somehow obvious if one thinks of how easily an epidemic might drive people crazy. He then draws our attention to the distinction between the normal and pathological fears, the latter often being disguised as expression of internal dangers based on unconscious fantasies. Sorry, disguised expression. So what's spoken about as a fear about the external reality is in fact an illustration of an internal fear based on unconscious fantasies, anxieties, and related defenses. Clients of mental health services may be particularly susceptible to fear and anxiety during this pandemic and therefore more likely to relapse, undoing many months, if not years, of careful progress and fearing that there is no way back. Given that we're all expected to don a coat of mild paranoia when leaving our homes, we can imagine how much more alarming this situation is for those who habitually fear mental or physical contamination from others. Orit Badug-Epstein, in a talk entitled "Lockdown is Where We Always Live," makes links between clients' responses to remote working with their attachment style. For some, the physical unavailability leads to a reawakening of trauma and rage that what is on offer is not good enough. For many clients, remote meetings can be quite traumatic. For example, one stranded at home together with her daughter, who screams down the phone at her key worker for the best part of her hour-long session. Her fear and rage, which invades the worker's mind, is also invading his personal space. For many clients, the loss of the therapeutic setting is very disturbing. Henri Ray coined the brick mother for the term the brick mother for the Maudsley Hospital because he saw how important the hospital was for patients who were afraid of breaking down and for whom it offered continuity and stability. On the other hand, some clients appear to experience relief that we're all in this together, and others who prefer not to venture outside their homes any more than is absolutely necessary are able to view themselves as socially responsible rather than psychologically disabled. As workers, we have to be aware of the increased psychological and physical risks to our clients, while simultaneously being aware of the risks to ourselves. Risks that arise when we are limited in our ability to assess a situation if we're only meeting people remotely together, and the additional risks to ourselves and our families should we decide that, in view of the level of concern we feel, a home visit to the client is unavoidable. We also need to be aware that we have no control over where we are heard or overheard, or indeed who sees us. This dynamic has become more evident since people began using visual as well as audio connections. We cannot be sure that our clients are able to locate a safe and private space in their home, and we know this has become even harder under lockdown. For example, a man with a restraining order against him who invaded and stayed in the female client's home at the beginning of lockdown, and the reported increase in domestic violence. One thing workers can do is share with a client a word or phrase that the client can use to signify that they are not free to talk, and perhaps another to signify danger. It's very difficult, as you'll see, to hold a state of patience when disconnected from one's client. The technology itself can be a source of anxiety, as Tim's already expressed. Will it work? What if I can't get connected? Or if I become disconnected? Have I lost contact or been switched off? Has the computer frozen, or is it stillness in the session? Silences can be more difficult, perhaps another reason why people feel an urge to chat. Then there are those clients with whom we cannot connect, and the difficulty of differentiating between what might be our own survival anxiety and that experience through our countertransference, especially if we think the client might be suicidal. Under what circumstances do workers decide that a home visit is necessary, with the risks, both professional and personal, this may involve, and weigh this up against the risks of not visiting? Workers report an urge to act to see their clients. Some, having decided to make a home visit, reported feeling shame at not having done so before, when they become aware of something that under normal circumstances they would have seen and acted on previously. At other times, meeting clients outside the home may go some way towards replacing the lost community base and enable workers to settle their clients and reassure themselves that the situation is under control. However, these meetings, although face-to-face, are not normal meetings insofar as they take place in public, outdoor, or socially distanced indoor spaces. So, the new norm. Lockdown plans were initially thought of as a temporary adjustments which range from focusing on supportive rather than exploratory work in order to manage clients' anxiety and limit the risk to postponing group work and putting new referrals on hold. Lemma concluded that she would only choose to work remotely with patients she had first worked with face-to-face, and this view was widely shared. However, as the months passed, it became clear that work in lockdown was becoming a new, not so temporary norm. Things could no longer be put on hold, and staff had to find ways of adapting to the situation. New referrals are taken on while other clients are discharged. And in this area, as in others, staff experiences mirror client experiences. The staff join and leave teams with no or only minimal face-to-face recognition of these transitions. Workers have been meeting and assessing new referrals remotely. This has led to a situation where some clients, while having weekly meetings with their worker, remain unseen. While it's possible for a worker to be curious and ask a client to describe themselves, we also need to be curious about what is lost in the assessment and in ongoing work with someone who has not been seen either face-to-face or remotely. On the other hand, clients in hospital or other residential settings who have to be seen are met by workers wearing full PPE, which in itself creates a barrier that is more than physical. As one perinatal worker commented, it's difficult to assess a mother's relationship with her baby when the baby is alarmed by my appearance. Over time, designated meeting rooms have been set up, enabling socially distanced meetings in which the wearing of masks is the only additional physical adaptation. So this helps. The easing of restrictions has in some ways introduced further dilemmas, though, regarding how to establish new ways of continuing the therapeutic work. For example, what began as an invitation to clients of a daycare service to meet each other in the park has developed over time into a walking therapy group. And this could be developed and expanded should the pandemic persist. Devising ways of providing therapeutic activities out of doors is not new. With reference to ecotherapy here. And we know that for some clients, working outdoors is preferable, notably those who experience claustrophobic anxieties and others for whom focused face-to-face work feels persecuting. Others have become accustomed to working remotely with groups and individuals, and while still noting the lack of human contact, can also recognise that in many cases, the work is no longer an impoverished version of the real thing, but is able to continue as before. On the other hand, staff are acutely aware that to expect a client to explore more deeply in circumstances where anxiety is high and the container, both physical and emotional, has changed, could push them to breakdown or suicide. And sadly, for some clients, it has felt as if the losses in containment have impeded progress. However, it's still hard to judge whether the stuckness could be solely attributed to the change in service delivery or whether it might have arisen anyway under normal working circumstances. Muzaffar Hussain notes that screen living is not new in our personal lives, where mobile phones and computers have been a means of seeing others for some time now. And as noted earlier, these methods of connecting may even be preferable for those clients who fear the outside world. However, even where our professional use of these means appears to have become well established, it's important to be open to inquiring about the difference in experience and to note what each person feels is lost or gained, exploring our counter-transferences to the technology as a means of both addressing the here and now reality and arriving at a deeper understanding of our clients and ourselves. This is a new heading, all in the same space. While we might enjoy a break from rush hour travel, this is offset by the loss of transition time and the challenges of having our clients in our home through phone or internet. Aspects of our lives that used to be separate, work, friends and family, are all now happening in the same space, and research has shown that this lack of variety renders us more vulnerable to negative feelings. That's a quote from Linville. It was written in '85. As time has gone on, people report feeling a flatness that's difficult to put into words. When someone used the word stagnant, to me, this seemed to fit. We're missing a liveliness, which in itself may render us less receptive and therefore increasingly vulnerable. And the BPC, the British Psychoanalytic Council, put something up a while back about Zoom fatigue, suggesting that Zoom fatigue has now entered our lexicon, and I'm sure we're all feeling exhausted after spending most of our days in teleconference sessions with patients or in online meetings and seminars, only then to use the same technology in the evening to talk to family and friends. Having initially wondered why I should feel unusually tired, I can now report that this is a common experience. Manu Jiang on BBC Work Life, speaking in April, quoted Giampiero Petriglieri saying, "Being on a video call requires more focus than face-to-face chat. Our minds are together when our bodies are not. The video call is our reminder of the people we have lost temporarily. It is the distress that every time you see someone online, such as your colleagues, that reminds you we should really be in the workplace together. What I'm finding is we're all exhausted. It doesn't matter whether they are introverts or extroverts, we're experiencing the same disruption of the familiar context during the pandemic." An additional anxiety is that of locating and maintaining a private space in homes we share with others, including children and pets, and the distraction of seeing oneself on screen and others in their home surroundings. Workers who live alone or lack a room to which work can be confined are particularly vulnerable at such times, and we may need to give some thought to what they are asked to take on. So back to the T. Emotional containment is the basis of all therapeutic work. Can the virtual container replace the physical team meeting space and enable team members to process their experiences, plan their work, and feel confident that their interventions are at least adequate? Teams are now meeting via the internet, and we're all in the process of evaluating and modifying this new experience. Reflective practice meetings are especially valued during these strange times. If under normal circumstances, all staff need protective spaces in which they can detoxify their experience, spaces where thoughts and feelings can be shared in order to reach greater understanding of their clients and of themselves, then surely these spaces become much more important at a time when we are all in unknown territory and when both workers and clients are more vulnerable and in many cases more disturbed. BBC Radio 4, File on 4, at the beginning of July, had a mental health worker on who sounded incredibly distressed just by everything she was going through and what her clients were going through. And my thought about that was they don't have reflective practice. She felt that she seemed to be very alone. She seemed to have lost her team, or at least the containment from her team. We're all vulnerable when we take the risk of sharing our disturbance, odd thoughts, doubts, and uncertainties, especially about our own practice. And in order to do this, staff need to feel safe and supported. If under these particularly difficult circumstances, teams can continue to resist the urge to act as a way of trying to alleviate the anxiety and instead locate a state of mind identified as patience, then staff teams can become the apparatus for thinking that which otherwise cannot be thought. That's a quote from Paul Hoggart in '92. A key part of creating a container for this virtual work is to name it. That is, to be explicit about what shape it is taking and to explore how different it is from the usual practice. We are all experiencing dissonance, and I suggest an all-pervasive feeling of loss as we are constantly reminded of what is missing. We need to acknowledge these things, recognise this work is tiring, take breaks between meetings, and allow time to explore the impact of the work, including the awareness of the home circumstances of colleagues and how this may impact on what they are able to take on. I've suggested that formal meetings be limited to 1.5 hours, allowing some time for chat before or after the formal meeting. Teams can do this now. So you put up the Zoom earlier, or you keep it on later, and people can say, you know, can I have a talk with you about so-and-so, or they can have a chat. Because these are the times in the team these are team times in which quite a lot goes on, really. You know, when you're going for coffee, or you're getting your lunch, or you're just getting ready for a meeting, or you're leaving a meeting, you're moving between rooms. This is work time in a way. It's important informal time. Stuff happens. So just conclusion, really. All governing bodies have produced documents advising workers about how to proceed. So I'm not going to repeat those. And advice will change as lockdown is eased or reintroduced or whatever happens. One thing we are currently being warned about and can be sure of, I suggest, and we are already experiencing some areas of work, is the increase in demand for mental health services that is coming in the wake of this pandemic. And you will know that the BPF has offered 6 free sessions to people if they wish them, if they're currently working and would like some help. Right, I'm going to finish there.